Welcome to the deep dive. Today we're doing something pretty critical, I think. We're digging into a detailed clinical case, one shared by a colleague, actually. Our goal here is to really get past the standard textbook immunity stuff and analyze the complement system. The body's incredibly powerful, but sometimes, yeah, self-destructive, double-edged sword. This deep dive is specifically for you, the clinician, the physician who deals with these complex, often non-infectious inflammatory conditions day in and day out. We're looking at a full immune and metabolic workup for a 44-year-old female patient. She presented with significant kidney injury, and the challenge really is connecting that microscopic immune activity, the complement pathway stuff we see in the blood work, to the macroscopic organ damage, we see in her urine, her filtration rate. We're looking for that aha moment, right? Understanding how the very system meant to protect her is basically causing friendly fire and driving this chronic tissue damage.
Exactly. This is really where clinical skill comes into play. It's not just seeing, oh, kidney function is off. We have to pinpoint the mechanism behind the damage, especially, when the usual suspects, classic autoimmune markers, acute infection screens, they all come back negative. The real key in this case study, I think, lies in those subtle but really profound anomalies in the complement system results. We need to answer, how does the C3 and C4 activation, which is, designed to fight off bugs, end up shredding the kidney's filter, the glomerular basement membrane? Understanding that pathway, well, that informs everything we do therapeutically.
Okay, that sets the stage perfectly. Let's jump right into the data then. Starting with the organ system that first raised the alarm, the kidneys. So the renal snapshot first. Looking at the basic blood chemistry, the usual markers, creatinine and urea, they seem, well, almost deceptively okay. Creatinine is 0.98 milligdl, urea is 32 milligdl. For a 44-year-old woman, yeah, that's technically within the normal reference range, but as every clinician listing knows, creatinine, it's a pretty late indicator of lost function, isn't it? The real insight comes from the calculated functional capacity.
Right, absolutely. You look straight at the estimated glomerular filtration rate, the eGFR. Using the CKD EPI 2021 formula here, the result is 73 LMN, 1.73 milliliters. Now, okay, it's not outright renal failure, but according to standard classifications, this puts her in the category of mild reduction in GFR. It's not CKD stage 3 yet, but it definitely shows her renal reserve is, well, shrinking. That's the first alarm bell. Subtle, yes, but it's early functional decline, and you absolutely have to figure out why.
Okay, so eGFR of 73 flags a functional stressor. Now, to pinpoint where that stress is happening, we look at the urinary markers. These give us almost like a real-time peek at the filtration barrier itself. The urine albumin creatinine ratio, the ACR, comes back at 33.75 milligram creatinine.
And that is definitive evidence of injury. A healthy kidney filter, it should hold on to virtually all albumin. An ACR of 33.75 milligrams puts this patient squarely in the moderately increased albuminuria range. We used to call it microalbuminuria, right? Officially, that's 30 to 299 milligrams. So for you listening, this is concrete proof that those delicate podocytes, the glomerular basement membrane, they've lost their integrity. The filter's leaky. Plasma proteins are getting through. And this isn't just, a bit of pressure damage from hypertension. This suggests a structural problem we need to explain.
And the urinalysis
Brown.
it doesn't just show a structural defect, it shows massive active destruction happening right now. We're looking at severe hematuria. The report says superior to 1 million millirin. Just to put that in perspective for everyone, the normal reference is what, up to 20,000 milliarea? So over 1 million. That's just astronomical.
Absolutely astronomical. That sheer volume of red blood cells, it confirms the membrane is rupturing. When you see hematuria in the millions, you're way past microscopic bleeding. You're looking at significant structural failure. This is classic evidence, really strongly suggesting an active, proliferative, or maybe even necrotizing glomerulonephritis. It means the filtration unit is under this fierce inflammatory attack that's literally breaching the capillary walls. And there's more too protein present, listed as +1, which is roughly 30 milligdl, and mild leukocyturia, 25,000 milli, just slightly over the 20,000 reference. But really, it's that hematuria that's the headline clinical feature confirming just how intense the localized damage is.
Okay, so kidneys clearly under attack. But before we zoom in on the immune system, we need to check the broader picture, right? Is this just a kidney thing, or is the kidney showing signs of a bigger systemic problem? The other findings suggest maybe more going on.
They certainly do. Look at the liver enzymes, the gamma-glutamyl transferase, GGT. It's sky high at 338 UL. For women, the reference is typically under 38 UL. So that's, nearly a 10-fold increase. Highly significant. Now, sure, GGT can go up due to alcohol or certain drugs, but in the context of what looks like immune-driven kidney damage, It strongly suggests pathology beyond just the renal system. It makes you think, okay, is there concurrent liver involvement, maybe biliary stasis from systemic inflammation, or just a severe generalized chronic inflammatory state that's really taxing the body's systems?
And then looking at her longer-term health profile, cardiovascular risk factors,
Yeah.
we see some things that often go hand in hand with chronic inflammation or these complex immune states.
Precisely. Vitamin D is deficient, really quite low at 9 ngml, and her LDL cholesterol is elevated at 145 mg/dl. These chronic metabolic issues, they matter because we know they can worsen systemic inflammation and contribute to microvascular damage. They could even potentially prime the blood vessels, making them stickier for the immune complexes we suspect are causing this problem. A damaged endothelium is, well, it's a sticky one.
Right. And crucially, we also need to talk about what this extensive workup has ruled out, because that's just as important for figuring out what's going on.
Oh, absolutely vital for narrowing down the possibilities.
Yeah.
So she's not reaching for syphilis, Hep B, Hep C. That eliminates common viruses known to cause immune complex issues. And maybe more importantly, in a glomerulonephritis workup, those key systemic autoantibodies, FAN or ANA, anti-DNA, anti-SSA, anti-SSB, anti-SM, they're all negative.
Yeah.
For our clinician listeners, that negative FAN,
Yeah.
it argues really strongly against most cases of systemic lupus SLE.
Okay.
So this pushes us away from the classic, well-recognized autoimmune disorders. It points towards something maybe non-standard, perhaps a secondary immune complex disease where the trigger, the antigen might be something unusual, maybe environmental, maybe a low-grade chronic bug, or even autoantigens that just don't show up on the standard tests.
Yeah.
But the mechanism, it almost has to be type 3 hypersensitivity, even without that typical SLE fingerprint.
Okay, so ruling out viruses, ruling out classic SLE, we're left with this picture of a severe localized immune attack on the glomeruli, which brings us squarely to the complement system. You called it the linchpin of the rapid response team. Let's get into that.
Right. The complement system. It's this incredibly intricate network. We're talking over 30 plasma proteins, mostly made in the liver, and its job is essential. Spot foreign surfaces, tag them so immune cells can eat them, that's opsonization via C3D, recruit more immune cells, and even directly punch holes in membranes to lympholize them. It gets switched on through three main routes, a classical, lectin, and alternative pathways. But they all kind of converge on cleaving C3 and then C5. C3 and C4 are our main markers here, reflecting what's happening with the classical and lectin pathways primarily.
So if the immune system is actively attacking the kidney, and that massive hematuria certainly suggests it is, we should see evidence of this rapid response team, the complement system, being activated in the blood work. Let's look at those specific results.
And this is where the clinical picture throws us a curveball, a real paradox. See, in many aggressive acute type 3 hypersensitivity conditions, think active lupus nephritis, or maybe severe cryoglobulinemia, you often expect to see low C3 and C4. Why? Because they're being used up, consumed in the attack, faster than the liver can replace them. But look here, C3 is 187.1 milligdl. The reference range is 90 to 180, so it's elevated.
High C4.
C4 is 45.1 milligdl, reference is 10 to 40, also elevated.
High C4 too.
And the CH50, which measures the total functional activity of the classical pathway, it's reported as superior to 96.00, the ml. The reference tops out at 95.00. So elevated.
Right. So the natural assumption, like you said, for a destructive process is consumption, using up the components. So why? Why are both C3 and C4 and the total functional capacity CH50 all registering high if the cascade is supposedly busy destroying the kidney filter?
Yeah, it's a critical diagnostic point. It helps differentiate phases and maybe types of immune complex disease. These elevated levels suggest a couple of main possibilities to me. First, remember C3 and C4 can act as acute phase reactants. So in some chronic inflammatory states, the liver might just ramp up production massively, sort of pushing the baseline higher. Second, and probably more relevant here, the pathology might be chronic, yes, but maybe the systemic consumption isn't overwhelming. Think of it like this. The immune complexes are depositing slowly, steadily, maybe over time, causing intense local activation and damage right there in the glomeruli. But the body's overall production rate is just cranking out so much C3 and C4 that it's more than keeping up with, even exceeding that localized usage.
Ah, okay. So the factories are working overtime, basically maintaining high levels in the blood, even while the battle rages specifically in the kidneys.
Exactly. The patient's body is essentially producing this huge surplus of immune ammunition. High circulating levels, even while those skirmishes at the glomeruli are ongoing. And that elevated CH50 confirms the potential for lysis, the full destructive capacity of her serum, is actually heightened.
So this pattern high complement, despite active glomerulonephritis, it's counterintuitive, but it's a really important clue. It helps distinguish this from, say, maybe a C3 glomerulopathy or a really severe SLE flare where you would expect to see that profound consumption, those low levels.
Precisely. Which leads us to the next crucial step, ruling out massive generalized inflammation as the cause of these high levels.
Right, because if this was just a reflection of the whole body being wildly inflamed, say from sepsis.
Then you'd expect other markers to be sky-high too. Specifically, you'd expect C-reactive protein, PCR, to be soaring. But look at her result. PCR is low, inferior to 0.4 milli-GDL. That's solidly normal. Also, the ASLO titer, the antistreptolysin O, is normal. That rules out a recent strep infection as a trigger, which can sometimes cause post-infectious glomerulonephritis. So the evidence really stacks up. The underlying problem isn't a generalized septic response. It's a focused, localized, immune complex-driven disease process happening primarily in the kidneys.
Okay, so the takeaway here is pretty clear then. The immune system is definitely hyperreactive. We see that in the high C3 and C4. But that activity seems to be specifically directed or maybe misdirected by these immune complexes, not by some widespread bacterial invasion. It's like an internal misdirection of an overarmed defense force.
Well put, an internal misdirection.
So we've established the outcome, the glomerulonephritis, the hematuria, the functional decline, and we've fingered the prime suspects, this highly active C3 and C4 pathway, even though the usual triggers, infection and classic autoimmunity aren't there. Now, let's get into the how, the mechanism. How does this protective system actually become the bad guy here via what you called type 3 hypersensitivity?
Right. Type 3 hypersensitivity or immune complex disease. Fundamentally, it's a problem of clearance. It starts when antigen-antibody complexes form. Now, unlike type 2 hypersensitivity, where the antibody attacks something fixed on a cell surface, here the complexes are soluble. They're floating around in the bloodstream.
Okay, but we've ruled out big infections and classic lupus. If your immune system isn't attacking a clear outside enemy or a standard self-target, what is the antigen in these complexes? What are they forming around?
That is often the million-dollar question in these less typical cases. Given her negative autoantibody panel, the antigen could be, well, almost anything. Maybe some unidentifiable environmental stuff she's been exposed to, a chronic low-level infection with some atypical bug the standard screens miss, or even possibly low-affinity autoantigens that just don't trigger the standard FANS but are still circulating. The key thing for type 3 pathology is that these complexes tend to form in a state of slight antigen excess. This makes them kind of intermediate in size.
And that size is important.
Critically important. These intermediate-sized complexes, they're cleared less efficiently by the body's cleanup crew, the mononuclear phagocyte system, macrophages, and so on, compared to really large complexes where antibody is dominant.
Okay, so these uncleared bundles of debris are floating around, and eventually they find somewhere to stick, and that's where the trouble really starts.
Exactly. They circulate, and then they deposit in vessel walls, particularly where blood flow is turbulent or where there's high filtration pressure, like the renal glomeruli. That's prime real estate for deposition. And once they lodge there, these complexes act like little magnets for complement. They become a fixed, stationary platform for continuous complement activation. They transform from just being debris into these highly reactive chemical targets right there on the vessel wall.
Let's talk about the physical consequences of that deposition, specifically for the physicians listening. The source material highlights key deposition sites.
Yes, in glomerulonephritis, where exactly in the glomerulus these complexes deposit, really dictates the pattern of injury we see under the microscope. And that's crucial for diagnosis, for prognosis. Typically, they lodge in one of three main spots. The mesangium, which is kind of the central supporting structure, the subendothelial space, so between the capillary lining cells and the main basement membrane, or the subepithelial space, which is between the basement membrane and those outer podocyte cells.
And why does that specific location matter so much clinically?
Well, if you're considering a kidney biopsy, knowing the likely mechanism helps predict what you'll find. This type 3 mechanism usually gives you that classic lumpy-bumpy pattern on immunofluorescence stating granular deposits of IgG and C3 along the capillary walls or in the mesangium. If the complexes are mainly subendothelial, they tend to provoke a really aggressive inflammatory response, often leading to proliferative GN, lots of cell influx, and, like in this patient, massive hematuria. If they're mostly subepithelial, you might see more of a membranous pattern, thickening of the basement membrane. But regardless of the exact spot, the point is these fixed complexes become these localized hotspots for nonstop complement activation. Even though her systemic C3 and C4 are high, we know that right there at those deposition sites, local consumption is intense, and that's what's driving the tissue damage we're seeing clinically.
Okay, so now we get to the actual destruction, the friendly fire phase. The immune complexes are stuck in the glomeruli, and that local activation you mentioned, that's the trigger for this whole amplification and signaling cascade.
Right, the complement cascade is built for rapid amplification. That initial cleavage of C3 and C4 it generates these really powerful breakdown products. And the key fragments here are C3A and C5A. These are the critical signaling molecules, the distress flares, if you will. They're the chemical link between the complexes just sitting there and the actual physical tissue damage that follows.
And they're called anaphylatoxins, but also potent chemotactic factors. Let's break down the anaphylatoxin part first. What does that mean locally?
Okay, so C3A and C5A are intensely inflammatory on their own. They bind to specific receptors on mast cells and basophils right there in the tissue. This triggers rapid degranulation, basically. These cells dump histamine and other vasoactive stuff. The result, right there at the glomerulus, profound local vasodilation, blood vessels widening, and increased capillary permeability, making them leakier.
So that leakiness worsens the protein spilling we already talked about with the ACR?
Exactly. It makes the proteinuria worse. But maybe more importantly, that increased permeability makes it easier for other inflammatory cells to get into the tissue from the bloodstream. It facilitates the recruitment phase. And C5A is particularly potent here. It's really the most powerful anaphylatoxin the system generates.
And that recruitment, you're saying that's the most destructive part. C5A sends out this signal, this beacon, attracting inflammatory cells.
Absolutely. C5A is a master chemotactic agent. Chemotaxis meaning it directs cell movement. It basically screams emergency here and guides huge numbers of polymorphonuclear cells. It's in neutrophils directly to the spot where those immune complexes are deposited. When we see severe active glomerulonephritis, especially with that kind of massive hematuria, we know there's likely intense neutrophil infiltration happening. These cells arrive, they see the area flagged by complement, and they basically interpret it as, a massive bacterial invasion that needs the nuclear option.
And these neutrophils normally are frontline defenders. They now act like, as you put it, indiscriminate cellular grenades, causing all this collateral damage.
Yeah, their job is immediate destruction. And they do it by releasing the contents of their lysosomes. We're talking powerful, non-specific enzymes designed to dissolve tissue. Things like myeloperoxidase, MPO, elastase, various metalloproteases. When these enzymes get dumped onto the very delicate, non-regenerating structures of the glomerular basement membrane and the cells around it, they cause rapid, widespread damage, necrosis, degradation. Elastase, for instance, literally chews through the structural proteins holding the filter together.
Okay, that localized enzymatic destruction definitely explains the protein leak, the microalbuminuria, but what specifically accounts for that absolutely massive hematuria, the million red cells per ml? That sounds like more than just enzymatic chewing.
It does. That level of bleeding points to active rupture of the capillary loops themselves. While the enzymes contribute, we really have to bring in the terminal complement pathway here. Specifically, the membrane attack complex, or MAC.
Ah, the MAC complex.
Right. Once C5 is cleaved, which happens downstream of C3 and C4 activation, it kicks off the formation of C5b. This then recruits C6, C7, C8, and a whole bunch of C9 molecules. These components assemble together, right on nearby membranes, to form the C5b9 complex. And this complex is essentially a transmembrane pore.
Like a molecular drill bit.
Exactly like a molecular drill bit. It inserts itself directly into the plasma membranes of cells in the vicinity. Normally the target's a microbe, but in this kind of type 3 pathology, the NIC complex forms on the local endothelial cells, the podocytes, and crucially, it can directly lace and rupture the thin walls of the glomerular capillaries. This direct pore formation by MA is a key reason for the severe active bleeding, the massive hematuria we see in this patient's labs.
Wow, okay. And then, just to make things worse, this local inflammation and injury also involves the blood vessels themselves, adding this layer of clotting problems.
Yes, the destruction feeds on itself, creating a vicious cycle. Tissue injury releases procoagulant factors. The intense local inflammation, plus the exposure of underlying collagen when the endothelium gets damaged, triggers platelet aggregation. Platelets stick together. This activates the coagulation cascade rapidly, right there in the tiny vessels. And the result is the formation of microthromby tiny clots within that intricate capillary network of the glomerulus.
So blockages within the filter itself.
Exactly. These tiny clots further obstruct blood flow. That leads to localized ischemia, lack of oxygen, hypoxia in the already damaged renal tissue. And that lack of oxygen severely worsens the damage already being done by the neutrophil enzymes in the MBC complex. It turns this localized immune attack into a cycle of progressive, potentially irreversible tissue destruction. And that underlies the patient's measured decline in eGFR, that drop in kidney function.
Okay, this has been an incredibly detailed walkthrough. We started with what looked like just a subtle dip in function, that eGFR of 73, but coupled with massive structural failure, the million-plus hematuria, and importantly, negative tests for the usual suspects like infection and lupus. Let's just quickly synthesize that whole chain of events we've laid out based on the sources for everyone listening.
Okay, so the clinical picture points strongly to a type 3 hypersensitivity, an immune complex-mediated glomerulonephritis. The sequence looks like this. Some kind of non-classical antigen exposure leads to soluble, intermediate-sized immune complexes forming in the blood. Because they aren't cleared well, they deposit in the kidney's filtering units, the glomeruli.
Right. And that deposition switches on the classical complement pathway. Systemically, we see that reflected maybe paradoxically as high C3, high C4, high CH50, a sign perhaps that the body's production is in overdrive, exceeding the localized consumption.
Then that local activation right there in the kidney generates those potent inflammatory signals, C3A and C5A. These act like flares, triggering massive neutrophil recruitment to the site. The neutrophils arrive and, acting like those cellular grenades, release destructive enzymes like proteases and elastase. At the same time, the terminal pathway forms the C5b9 MAC complex, which directly punches holes in the capillary membranes.
And the clinical result, confirmed by this patient's data, is acute destructive glomerulonephritis. We see the early functional decline, eGFR 73, the massive structural damage, hematuria 1 million, and the leaky filter, microalbuminuria 33.75 milligram crete.
And the clinical importance, the real takeaway for the treating physician, is understanding this specific pattern. We've established it's not sepsis, low PCR, it's not classic SLE, negative FAN anti-DNA. Therefore, the management strategy really has to focus on controlling whatever is causing those immune complexes to form, and critically, on neutralizing the activity of the complement cascade itself.
So we've moved from just diagnosing the kidney problem to thinking about targeted therapy based on the mechanism. Understanding the role of C3A and C5A as the key drivers of that neutrophil damage. That seems like a huge clinical leverage point.
It really is. Because if you just throw broad immunosuppression at this, you might eventually dampen down the antibody production, sure. But those complexes that are already stuck in the kidney, they'll keep driving local destruction via complement until they're somehow cleared. This mechanistic insight highlights why therapies focused on direct complement inhibition might be useful. Things like agents that block C5 cleavage, stopping C5A and MAC formation, or maybe even physically removing the complexes with plasmapheresis, especially if things are progressing really rapidly. It's about treating the mechanism, not just the symptom of inflammation. We're targeting that C3A, C5A signaling, targeting MAC formation.
It really underscores that core lesson from immunology for us as clinicians. The body's protective systems are powerful, but they operate on this incredibly fine line, this razor edge of control.
Absolutely. The kind of profound consequences we see here, potential permanent kidney damage, the need for long-term management, they happen because that precise, localized regulation of this ancient, powerful system gets lost. The complement system, vital for protection, transformed into an agent of disease itself, all because it was misdirected by these antigen-antibody complexes.
This has been a really illuminating look at how one of the body's core defense structures can, under certain chronic conditions, effectively turn on itself, driving non-infectious damage with, well, devastating efficiency. Thanks for walking us through that complex synthesis of the clinical data and the underlying molecular pathology.
Oh, my pleasure. It's fascinating stuff to unpack. And for the physicians listening, I think the lesson is always look deeper than just whether a marker is high or low. You need to understand the kinetics, understand the specific pathway involved, understand which specific fragments like C3A and C5A are actually causing the damage.
And as we wrap up this deep dive, we want to leave you with a final thought, something critical that builds on everything we've discussed about the complement system today. We've shown how C3 and C4 activation, when it's misdirected by these immune complexes, can cause truly catastrophic, potentially irreversible tissue damage.
So maybe consider this. How many other systems in the body, systems we see as purely protective, things like coagulation, maybe aspects of inflammation, even certain metabolic cycles might also have this hidden, double-edged nature? Are they too constantly navigating that incredibly fine line between defense and potential self-harm? We absolutely rely on them for survival. But what other kinds of stressors, environmental, chronic, maybe things beyond the immune complex as we talked about today, could potentially tip that delicate balance? Could they turn these vital systems against us, demanding completely new, highly specific ways for us to intervene therapeutically and try to restore that control?
Something to definitely think about until our next deep dive.